Maybe you've never had what you'd call heartburn. No burning in your chest after a meal, no fire rising into your throat, nothing you'd describe as painful exactly. But every morning there's something, a thickness, a film at the back of the throat that won't clear. You find yourself reaching for water first thing, not because you're thirsty, but because there's something there that shouldn't be. You've cleared your throat so many times it's become automatic. You don't even notice anymore. You've mentioned it to a doctor maybe. You've been told it might be allergies, post-nasal drip, dry air, getting older, and the word reflux, it may never have come up because you don't have the classic symptoms. I want you to stay with me because what I'm going to describe in this video may be the most consistently misidentified pattern I encounter in my practice when it comes to digestive health after 60. And understanding it, really understanding what's mechanically happening, changes not just how you treat it, but how you think about it. I'm Dr. Rose. I've been practicing medicine for 12 years, working primarily with adults over 60, and the reason I started making videos about reflux, specifically about this mechanical angle, is that I kept seeing the same thing in consultations, patients arriving with persistent throat symptoms on 2, sometimes 3 medications. And when I'd ask them to describe how the problem was explained to them, they could tell me what they were taking, but almost none of them could tell me why the reflux was happening in the first place. And that gap between here's your prescription and here's what your body is actually doing is precisely where people stay stuck. This video is not a list of foods to avoid. It's an explanation of the mechanism, because once you understand what's failing, the choices you make start to make real sense, not just as instructions, but as logic. If this kind of medicine is useful to you, not just the what, but the why, please subscribe. I post here every week, and I try to make every video worth your time. Most people understand acid reflux something like this. The stomach produces too much acid. That acid rises up. It burns the esophagus, and the answer is to reduce the acid. Take omeprazole, take pantoprazole, problem managed. And I want to be precise here because I'm not going to tell you those medications are wrong. When there's active inflammation in the lining of the esophagus, esophagitis, or when there's an ulcer or Barrett's esophagus, reducing acid production is genuinely protective. It allows injured tissue to recover without being continuously assaulted. I prescribe these medications when they're indicated. That remains true. But here's what that picture leaves out. Acid is not the enemy. Acid is necessary. It destroys harmful bacteria that enter your stomach. It breaks down protein so you can absorb it. It activates the signals your body needs to take in vitamin B12 and certain minerals. Your stomach produces acid for good, specific reasons. The problem, and this is what I want to be very clear about, is not that acid exists. The problem is that the acid goes somewhere it was never designed to go. And in most people, the reason it travels upward is not primarily that there's too much of it. The reason is mechanical. Something that was supposed to stay closed isn't staying closed. Let me give you a picture of what's happening inside your body. Imagine your stomach as a balloon, a soft, flexible container filled with liquid, gas, and digestive enzymes, all doing exactly what they should do, right where they are. That's your stomach after a meal. Now, between that balloon and the tube that connects your mouth to your stomach, your esophagus, there is a muscular ring, a valve. Physicians call it the lower esophageal sphincter. Think of it as the knot at the top of the balloon. When that knot is strong, when it's tied correctly, the contents stay inside. When you swallow, the knot opens briefly to let food travel down, then closes again immediately. The system works, but when that valve is weak, when the knot is loose, or when it relaxes at the wrong moment, or when the pressure inside the balloon has built up enough that it forces the knot open, the contents of the stomach travel upward into the esophagus, into the throat, and sometimes further than that. That is reflux, not excess acid, a valve that isn't doing its job. And that distinction between an acid problem and a pressure and valve problem changes everything about what intervention actually makes sense. I want to come back to the person I described at the beginning, the one who clears their throat every morning, who doesn't have heartburn, but has that persistent something, that film. There's a form of reflux that a significant portion of physicians, not all but many, are slower to recognize. It's called laryngopharyngeal reflux, abbreviated LPR, sometimes called silent reflux. In laryngopharyngeal reflux, the stomach content that travels upward doesn't always produce the burning sensation in the chest that most people associate with the condition. Instead, it reaches higher, into the throat, the larynx, sometimes the region just behind the nasal passage. And the irritation there isn't caused only by acid. It's also caused by an enzyme called pepsin. Pepsin is a digestive enzyme. Its job is to break down protein inside the stomach. But when it travels upward and lands on throat tissue, which was not designed to handle it, it can adhere to the lining there, and it can continue to cause irritation long after the reflux episode itself has ended. Here's the part I want you to notice. Pepsin is reactivated by acidity. So even hours after the original reflux episode, if you eat or drink something acidic, the pepsin that's already sitting in your throat tissue becomes active again. That's why some people have that persistent rawness, that thickness, even on days when they haven't eaten anything obviously triggering. The enzyme is already there, and it keeps being activated. The symptoms of laryngopharyngeal reflux often look like this: a sensation of something stuck in the throat, what physicians call globus, a need to clear the throat repeatedly, especially in the morning, a dry cough, often worse when lying down or after eating, hoarseness, particularly when first waking up, a feeling of excess mucus or thickness at the back of the throat. Because these symptoms live in the throat and not the chest, many people, and honestly some physicians, don't connect them to the stomach at all. They look like allergies, like postnasal drip, like a mild infection that never quite resolves. I've sat with patients who spent more than a year treating assumed allergies before someone noticed the actual pattern and said, "This is coming from below, not from above." This is the part most people miss. Before we move into what you can actually do, I want to slow down for just a moment, because I've given you quite a bit of information, and I want to make sure the foundation is solid before we build on it. Reflux is, at its core, a problem of pressure and valve function, not just a problem of acid volume. It presents in two major ways: the classic pattern with burning behind the sternum, and the silent pattern with throat symptoms, morning mucus, and chronic cough that most people never connect to their stomach. Medications that reduce acid production serve a real purpose when there is tissue injury, but they don't mechanically strengthen the valve. They manage the consequences of the valve failing. They don't repair the valve itself. So, if the valve is the actual problem, what does? That's where we're going now. I want to walk you through 3 levels of intervention, not because everyone needs all 3 simultaneously, but because understanding the logic behind each one allows you to approach your own situation with some intelligence rather than guesswork. Level 1: mechanics, pressure, and position. The valve fails more often when the pressure inside the stomach is too high. So, the first category of intervention is reducing that pressure directly. The most direct way to do that is to not overfill the stomach. There's a concept I've started mentioning to patients in the last few years that comes from Japanese eating culture. The phrase is hara hachi bu. It translates roughly as eat until you're 80% full. I don't offer this as a cultural curiosity. I offer it because the physiology behind it is sound. Most of us know the difference between feeling satisfied and feeling stuffed. Satisfied is comfortable. You stop thinking about food, but you're not uncomfortable. Stuffed is that heaviness, that sense that the stomach is straining, that slight bloating, that pressure. That second feeling, that strain, is exactly the internal pressure pushing against the valve. If you regularly eat past that point, you are regularly loading the valve with more pressure than it may be able to hold, especially if, as tends to happen after 60, the sphincter's resting tone has decreased somewhat with age. The goal isn't to be hungry. The goal is to stop before the pressure builds. There's also the question of liquids during meals. Drinking large amounts of water or other beverages while eating increases the total volume inside the stomach. For some people, this worsens reflux. If you notice a correlation between drinking a lot during meals and your symptoms afterward, try sipping less during the meal itself, drinking more freely between meals instead. Now, position. And this is where I want you to pay close attention, because most people don't know the anatomy behind this. Your stomach is not a symmetric organ. It sits slightly to the left, inside the abdomen, and its shape means that when you lie on your right side, the opening that connects the stomach to the esophagus is positioned lower, making it easier for the stomach's contents to drift toward the valve and upward. When you lie on your left side, the geometry reverses. The stomach settles in a way that keeps its contents further from that opening. The esophagus points slightly upward relative to the stomach contents. Gravity is working with you, not against you. This is not a minor detail. The association between left side sleeping and fewer nighttime reflux episodes is well documented. If your symptoms are worse at night, that cough when you first lie down, the throat clearing at 2 o'clock in the morning, your sleep position is one of the first things worth examining. If sleeping on your left side isn't comfortable for you, or if you move during the night, the next best approach is elevating the head of the bed. I want to be specific here. I mean raising the bed frame itself at the head, placing something stable under the legs to create a gentle slope of about 6 inches or 15 centimeters. This is not the same as adding more pillows under your head. Pillows can bend the body at the waist and actually increase abdominal pressure. The elevation needs to be from the hips upward, and the window between your last meal and lying down matters. 3 to 4 hours is not an arbitrary number. Your stomach empties roughly half its contents in the first 90 minutes after a meal, but it takes significantly longer to approach full emptying. Lying down with a stomach that's still in the middle of processing a large meal means losing gravity's support at precisely the wrong moment. One more thing in this category: external pressure on the abdomen. Tight waistbands, belts pulled. Firmly, shapewear that compresses. Bending forward at the waist after eating. All of these increase the pressure pushing up against the valve from the outside. Your posture and clothing in the hour after a meal are more relevant people consider. Level 2, the alginate barrier. Most people have come across antacids, the tablets or liquids that neutralize acid in the stomach. They're fast and useful for occasional mild symptoms, but there's another category of intervention that works entirely differently and that I think is significantly underused. It's called alginates. Alginates Gaviscon is the most widely known brand, though formulations differ by country, work not by changing the acid level inside the stomach, but by forming a physical barrier on top of the stomach contents. When alginate comes into contact with stomach acid, it creates a gel-like raft, a floating layer that sits on the surface of the gastric contents. Think of it as a physical lid placed over what's inside the balloon. Even if the valve loosens, even if there's momentary reflux, this barrier intercepts the content before it can travel far. For people whose reflux is primarily positional and pressure-driven rather than caused by acid overproduction, alginates are often more mechanically logical than long-term acid suppression. They're typically taken after the main meals of the day and before sleep. I'm not suggesting they're appropriate for everyone, but if you've never tried them and if your symptoms are primarily after eating or lying down, they're worth discussing with whoever is managing your care. Level 3, protecting the throat. This level applies specifically to laryngopharyngeal reflux, to the people with throat symptoms, morning mucus, and the chronic cough. If pepsin has already traveled into the throat and is adhering to the tissue there, the mechanical approaches help prevent more from arriving. But what about what's already there? Pepsin becomes inactive in an alkaline environment, in conditions where the pH is higher. When acidity increases in the throat, it reactivates. This is the logic behind something that sounds almost too simple to matter: gargling with alkaline water or with a small amount of bicarbonate dissolved in water after meals. Not as a treatment for the underlying reflux, that still requires the mechanical work, but as a way to help deactivate pepsin that has already reached the throat tissue. To reduce the continued irritation between episodes, it won't resolve the condition on its own, but it can meaningfully reduce that persistent rawness and the need to constantly clear the throat, particularly in the morning. There are 4 substances I want to address specifically because they interact directly with the sphincter muscle itself, not just with acid levels. Mint, peppermint, spearmint, the teas and lozenges many people reach for when they feel digestive discomfort. There is a genuine irony here. Mint can relax the lower esophageal sphincter. The very thing meant to soothe digestion may, in some people, be loosening the knot. If you use mint regularly and your reflux is persistent, this connection is worth examining before assuming you need a stronger medication. Chocolate. Chocolate contains 2 things that work against the valve: theobromine, which can relax the sphincter, and fat, which slows how quickly the stomach empties. A stomach that empties slowly stays under pressure longer. The combination makes chocolate a fairly reliable trigger for many people with valve-related reflux, not because it's acidic, but because of these specific mechanisms. Alcohol. Alcohol irritates the lining of the esophagus directly and relaxes the sphincter. It's also most commonly consumed in the evening, exactly when people are preparing to lie down. This timing concentrates the risk. 1 drink before dinner is a different physiological situation than a drink close to bedtime. Tobacco. Nicotine reduces the resting tone of the lower esophageal sphincter, not occasionally, chronically. In people who smoke, the valve is persistently less tense than it should be. This is one of the more consistent findings in reflux research, and it's not a small effect. If any of these appear regularly in your life alongside persistent symptoms, the connection is not incidental. Coffee and tomatoes deserve a more careful answer than a blanket avoid them. The research on coffee and reflux is genuinely inconsistent. Some people with significant reflux tolerate coffee without any noticeable correlation. Others find a clear connection. The same is true of tomatoes, citrus, and spicy foods. The mechanisms differ. Some irritate directly, some stimulate acid, but the individual variation is real. My approach with patients for these foods is not eliminate them permanently. It's if your throat is currently irritated, if your symptoms are active, remove them temporarily. 2 to 3 weeks. Give the tissue a chance to calm down, then reintroduce them one at a time and notice what your body does. Your body will tell you what it tolerates. It gives that information accurately. The difficulty is that when several variables change at once, the signal gets lost. By removing and reintroducing individually, you create conditions where the signal is clear enough to read. The goal is not a permanent restricted diet. The goal is understanding your own pattern, so you can make choices with information rather than fear. I want to address this directly because it comes up in nearly every conversation I have about reflux. The theory behind apple cider vinegar for acid reflux is this. In some people, particularly as acid production naturally decreases with age, the stomach may actually not be producing enough acid. And paradoxically, low acid can worsen reflux because the incomplete digestion increases fermentation, which increases gas, which increases pressure on the valve. There is some physiological sense in that explanation for a specific subset of people, but here is my concern. If you are currently experiencing active symptoms, burning when you swallow, pain, visible signs of esophageal inflammation, your esophageal lining is already irritated. Adding an acidic substance, even a natural one, is a bit like applying something caustic to an open abrasion. The tissue doesn't distinguish between healthy acid and damaging acid. It simply registers more injury. Apple cider vinegar is not where I would begin for someone with active painful reflux symptoms. If you've been managing reflux for some time, if you have reason to believe acid underproduction may be a factor, and if you've ruled out esophagitis, that's a different situation. But that's a conversation to have with someone who knows your specific history and has looked at your specific picture. Starting with vinegar when the throat is raw is not a safe first step. I'll be honest with you about something before we close. Not every persistent cough is reflux. Not every thickness in the throat is pepsin. There are other causes that deserve investigation. allergic rhinitis with postnasal drip, asthma presenting primarily as cough, laryngeal hypersensitivity. And one that doesn't get mentioned often enough, certain blood pressure medications, specifically ACE inhibitors, enalapril, lisinopril, ramipril. A dry, persistent cough is a well-documented side effect of this medication class. If you take one of them and you've developed a new chronic cough since starting it, please mention it to the physician who prescribed it. The answer may be a medication adjustment, not a digestive intervention. If you apply the mechanical strategies we've discussed today and your symptoms don't genuinely improve within 2 to 3 weeks, not just vary but improve, it's time to look for other explanations with a professional rather than continuing to assume it's reflux. And then there are the symptoms I want to be direct about. Swallowing that is becoming progressively more difficult, not occasional, not just once, progressively more difficult. A sense that food is getting stuck, happening more often, in more situations, chest pain that you cannot clearly distinguish from a cardiac symptom. If you're not certain it's digestive, do not assume. See someone. This matters particularly after 60. Blood in vomit or vomit that looks like dark coffee grounds, stools that are dark or tarry, unexplained weight loss, anemia without a clear cause. These symptoms can indicate conditions that require proper evaluation: Barrett's esophagus, an ulcer with active bleeding, a stricture in the esophageal wall. These situations are not managed with home protocols. They require a clinical eye and often an endoscope. If any of these apply to you, please do not wait. This is not the territory for uncertainty. There's something I've come to believe firmly after 12 years of this work. The patients who do best after 60 are not always the ones with the cleanest test results. They're the ones who understand their own bodies well enough to notice when something has changed, and who know the difference between this is manageable and this needs attention. Reflux is not just excess acid. It is a pressure problem, a valve problem, a positional problem, and sometimes a chemical environment problem. Understanding which of those applies to your situation is what allows you to respond with something targeted, not just something generic. Reducing acid without addressing the valve is like lowering the water pressure in a house without repairing the leaking pipe. The damage slows, but the pipe is still leaking. What I've described today isn't a protocol designed to replace your physician. It's information that helps you participate more intelligently in your own care and make more informed choices about your own body. Your digestive system doesn't operate in isolation. It is one of the systems that quietly sustains everything else. Your energy, your sleep, your capacity to absorb